I'm going to briefly give you an overview of the toolkit that has been developed by HANYS and how give you my experience in using many elements of this toolkit to implement stewardship in several nursing homes in the Rochester area. And I'm going to follow the 7 core element of the recommendation by the CDC. And so it's recommended by the CDC that you start your program by getting leadership commitment, accountability, and expertise. What I want to emphasize, for any project to be successful and sustainable, you really need a core of people that are interested and that can work together to make this program succeed. So it is very important, in addition to the leadership commitment, to get a team together to work together on implementing a stewardship program. And so in the toolkit, you will see some letters, commitment letters that can be changed and modified to your needs. And I want to emphasize that it's important for administrators in your facilities to really, the leadership support letter is by itself a document, but how can you really implement it in real life? How can you get the administrator to kind of say, I really value this program? What they can do is make sure that they identify or help identify a leader to oversee the antibiotic stewardship program. And the other way they can show that they are endorsing this program is to make sure there are resources available to give people time to do the work that is needed for the stewardship program, and to promote the needed quality improvement, support training and education. Sometimes you need to send someone to get trained in antimicrobial stewardship or infection control. So all these measures can show that leadership really support the program. Another way that they can support the program is to be present at either quality meeting that discuss antimicrobial stewardship result or antimicrobial stewardship meeting. Now, when you can decide who is the leader of your project, and it's really important to get the medical director engaged. I am aware that many facilities don't have medical director on site, but truly to be able to change prescribing behavior, you really need to have a medical director that oversees other provider that prescribe in the facility and be able to provide feedback on their prescribing. Without that feedback and the regular review of antibiotic utilization, infections that might be related to antibiotics such as C. diff, these are all very important. And what the medical director can also do is develop policies and protocols for antibiotic use, for example, for community-acquired pneumonia, for pneumonia in general, for skin and soft tissue infection, or for urinary tract infection. And these toolkits have some guidelines that we developed at the University of Rochester to help with development of policies and protocols for treatment of these common infections. And it's also important for the medical director to be a role model and to be an educator. And the education doesn't have to be, set in stone like once a week, or it could be as you're giving the feedback to several providers about their prescribing. The nursing director also play a very important part. As you know, nursing are the ones that are available 24 hours a day to assess the residents. So it's very important for the nurse director to educate their staff on the residents' change in condition, and to highlight the importance of communication with provider and documentation of their finding. And this toolkit includes the link to the AHRQ toolkit that have SBAR tools and other tools that can be used to improve the assessment and the communication of nursing. So the nursing director can also educate of what is the importance why is it important to have an antimicrobial stewardship program, and why we don't treat, for example, urinary tract infection without sign and symptoms. So all this could be a very important role for the nursing director. The infection preventionists, even though they're really playing right now a very important role in implementing antibiotic stewardship, they cannot be the sole, the sole person responsible for this program, because they have a lot of roles to fulfill. They help, with tracking of data such as antibiotic use and infection, which, for example, you can track C. difficile as an outcome of, overuse maybe of some certain of antibiotics such as quinolone. They're also responsible to report to the COAPI meeting and educate staff and residents. And they can also try to see if they're implementing the policies. For example, we have many IPs in our region who are manually collecting data on antibiotic use. If it's, for example, a UTI, they're able to dig deeper and find out, is the antibiotic used the right antibiotic because the culture came back? Is it a sensitive organism? Is the duration the recommended duration that was developed in their policy? So the infection preventionist, role is important, but I just want to highlight that she or he should not be the sole person responsible for this program. I feel it's very important for a provider that is prescribing to get feedback as well from other medical providers, such as the medical director, or from a pharmacist. So the pharmacist really is an important team member of the antimicrobial stewardship and has the expertise in antibiotic, and they can do, through their monthly review, they're able to see if there is documentation of indication, duration, doses. They can also focus maybe if there is a lot of quinolone use on the quinolone use. Is it appropriate? Is there an alternative agent? And they're very important to identify interaction. For example, if you are on blood thinners and you're taking quinolone, if you're on, you get started on trimethoprim sulfa, what's your potassium? Is your creatinine clearance adequate to use the regular dose, or do you need a lower dose? And they're also very important to see what is on formulary. For example, if you want to reduce the use of quinolone for urinary tract infection, do you have the alternative which is now recommended, such as nitrofurantoin? Is nitrofurantoin in your emergency drop box? And they can provide feedback to provider. I'm aware that feedback can be after the fact, but the more you emphasize the message of what's appropriate, what could be changed, people learn and change their prescribing behavior. The pharmacist also needs to really work very closely with the medical director. So sometimes it's very hard to get feedback to provider about their prescribing. Both, for the pharmacist and the medical director will need to work together to address, or change the behavior of some of the prescribers that are a little bit, pushing back for change. And so the pharmacist can do a deeper dive and, see what's good, what's bad, are the policies followed, what is the, how much quinolone we're using, how much antibiotic we're using, what are you using them for, and, track, for example, the consultant pharmacist or the dispensing pharmacist, if they're in-house, they can look at, what are we using for urinary tract infection, what proportion is quinolone, how many antibiotic start do we have for a UTI? If we're thinking that we're using a lot of treatment for UTI that's asymptomatic bacteriuria, you can monitor over time with the education how that change is done. And it is not truly in the toolkit or in the CDC guideline, but it's also important to include the Microbiology Lab that can provide a cumulative antibiogram. Sometimes you don't have enough isolate to develop that antibiogram. There are toolkits out there, and we have links to them. It's important that only one isolate is reported per year per resident. And most of the antibiogram use is probably for urinary tract infection, because this is the most common source of culture in the nursing home. The microbiology lab can also provide, what is the number of urine cultures. So, for example, we started working with a nursing home, and we realized that the number one use of antibiotic in the facilities, almost 100% of the facility we work with was urinary tract infection. And we dug deep into the cases, and we realized that there is a lot of people being treated for asymptomatic bacteriuria. We also realized there is a lot of treatment for or prophylaxis for UTI. So what we did is we educated provider, nurses, family on the appropriateness of diagnosing UTI and who should be treated. And so what you could do is, over time, you could see if there is less people being cultured by reducing the number of inappropriate culture. And it's important to reduce the over-testing, because most of the urine in the nursing home tend to be positive, either because it's contaminated or people are colonized. And it's very hard to look at the urine that's positive and not to treat. So it's better to be very judicious of who you are treating, who you are testing, and make the right decision of who you're going to treat. This is also important, and to emphasize, when you have a stewardship program, is everyone is on board and understand what are the policies of the facilities. For example, for floor nurses, make sure that they're getting the proper culture, because contaminated urine can be kind of a problem. So are they getting the culture the right way? Educate them on signs and symptoms of urinary tract infection or other sign and symptom, respiratory infection. What could it be? Upper respiratory? What could be lower respiratory tract? What are some warning signs that you need to contact someone immediately? And how do you communicate this information so the person on the phone or the person reviewing the chart knows really what they're dealing with and can help them with their decision to prescribe or not to prescribe? They can also administer antibiotic well. Sometimes we write an antibiotic order and it's not given for several hours. It's very important that the nurses are aware that an antibiotic needs to be given for an infection as soon as possible. And they can play a role in reassessment of the patient that is started on antibiotic or is culture waiting for antibiotic, and they can document how is the patient doing, or reach out to a provider if the patient is not doing well within the 48 hours to 72 hours after they start antibiotic. And that's it for the first portion of the toolkit.